Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the knee. In this lecture, we're going to discuss the ligaments and the menisci of the knee, the actions and muscles, innervations of the knee as well, and the popliteal fossa. Now, I'll be back later for some clinical correlations and the end of session quiz. But for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
There are two joints at the level of the knee. The tibiofemoral joint, which is commonly called the knee joint, and the patellofemoral joint. The patella is the largest sesamoid bone in the body. Sesamoid bones are embedded in tendons, usually at a point where the tendon is crossing a joint. The patella is embedded in the quadriceps tendon and is connected to the tibial tuberosity via the patellar ligament. The patellar ligament is often clinically referred to as the patellar tendon, but anatomically it fits the definition of a ligament in that it connects two bony structures, the patella and the tibial tuberosity. The patella lies in the intercondylar groove at the distal end of the femur, forming the patellofemoral joint with the femur, which is a synovial gliding joint. The patella slides superiorly and inferiorly in the intercondylar groove as the knee joint is extended and flexed. The main biomechanical function of the patella is to increase the torque, or rotational force about the knee, produced by the quadriceps muscle group. It does this by increasing the lever arm of the quadriceps. The lever arm is the distance between the quadriceps tendon and the center of the knee joint. Torque varies with lever arm length. A longer lever arm means more torque. As the knee joint is extended, the patella rises out of the intercondylar groove, significantly displacing the quadriceps tendon anteriorly, thereby increasing the length of the quadriceps lever arm, which results in greater torque. This means the quadriceps have to produce less force in order to achieve full extension of the knee. Patellectomy reduces the lever arm of the quadriceps, thereby increasing the amount of force required of this muscle group to produce the same degree of knee extension. Full knee extension following patellectomy requires 30% more quadriceps force than is required in an intact knee. Removal of the patella also results in a decrease in the range of motion of the knee joint and degenerative changes, such as arthritis in the tibiofemoral joint, that appear to arise in response to biomechanical abnormalities. The tibiofemoral joint is an articulation between the convex femoral condyles and the mostly flat tibial condyles. The tibial condyles are located on the superior aspect of the tibia, which is also called the tibial plateau. The fibula does not articulate with the femur and is not a weight-bearing bone. The knee is a synovial joint. Its joint capsule is thin, but it's strengthened by the many muscles that attach around the knee and whose tendons blend in with the capsule. The capsule attaches to the femur superiorly, just proximal to the articular margins of the condyles. Posteriorly, it encloses the condyles and the intercondylar fossa. It has an opening posterior to the lateral tibial condyle to allow passage of the tendon of the popliteus muscle on its way to inserting on the tibia. Inferiorly, the joint capsule attaches to the margin of the superior articular surface, or tibial plateau of the tibia, except where the tendon of the popliteus crosses the bone. Anteriorly, it is continuous with the medial and lateral margins of the quadriceps tendon, the patella, and the patellar ligament. The synovial lining of the knee joint bulges superiorly to form a suprapatellar bursa that reduces friction between the quadriceps tendon and the femur during extension and flexion of the knee. Posteriorly, a gastrocnemius bursa forms as an extension of the synovial lining, between the medial head of the gastrocnemius muscle and the femur. While we're talking about bursa, there are a pair of bursa that may become inflamed and swollen upon extended periods of kneeling on a hard surface. These are the prepatellar bursa, which is superficial to the patella, and the infrapatellar bursa, which is superficial to the tibial tuberosity. The condition colloquially referred to as water on the knee is swelling of these bursa. The tibiofemoral joint is held together by two pairs of ligaments, the cruciate ligaments and the collateral ligaments. The lateral collateral ligament of the knee, or fibular collateral ligament, is a well-defined cord of fibrous connective tissue that is extracapsular, that is, outside of the capsule of the knee joint. It attaches to the lateral epicondyle of the femur and the head of the fibula. The medial collateral ligament of the knee, or tibial collateral ligament, is a broad, flat ligament that blends in with the capsule of the knee and is thus considered to be capsular. It attaches to the medial epicondyle of the femur and the medial condyle of the tibia. As their name implies, the cruciate ligaments cross each other, forming an X. They are intracapsular but extrasynovial. That is, they are within the joint capsule, but they are not within the synovial lining. They are named according to their relative attachments to the tibial plateau. The anterior cruciate ligament attaches to the anterior intercondylar area of the plateau, while the posterior cruciate attaches to the posterior intercondylar area of the plateau. The other ends of the cruciate ligaments attach to the femur, the anterior to the lateral condyle of the femur, and the posterior cruciate to the medial condyle of the femur. The anterior cruciate ligament resists sliding of the tibia anteriorly with respect to the femur, or sliding of the femur posteriorly with respect to the tibia. The posterior cruciate ligament resists the opposite actions, sliding of the tibia posteriorly with respect to the femur, or sliding of the femur anteriorly with respect to the tibia.
It's time for a clinical correlation. So first I want to spend a little bit of time talking about the anterior cruciate ligament tear. Now, the anterior cruciate ligament, or ACL, is a primary stabilizer of the knee. Now, a tear to the ACL results in a rotational or hyperextension force applied to the knee joint that overcomes the strength of that ligament. Now, although partial tears can occur, injuries involving the ACL more often result in a complete tear. About half of the time, an ACL tear is accompanied by a significant meniscal tear, and we'll discuss the meniscus of the knee here in a second as well. Now, patients with ACL tears usually report sudden pain and giving way of the knee from a twisting or hyperextension type injury. 1/3 of patients report an audible pop as that ligament tears as well. Now, a patient who sustains an ACL tear during athletic activity is usually unable to continue participating because of pain and or instability. Now, the most sensitive test for ACL insufficiency is called the Lockman test, in which the knee is flexed to about 25 degrees and the tibia is gently pulled forward while the femur is stabilized. Increased motion of the tibia with no solid endpoint indicates a tear of that ACL. Now, there's another thing called the anterior drawer test, and that's also performed to see if the ACL is intact, and that's performed with the knee flexed further at about 90 degrees. Now, with the knee bent, the tibia is again pulled anteriorly in the same manner that you would open a drawer. So that's how you remember that one. Also, in a similar manner, the posterior drawer test can be performed by pushing the tibia with the knee flexed in that same 90-degree position. And that's another way you're pushing a drawer closed. Now, this tests the posterior cruciate ligament, or PCL, and it's negative in about 50% of acute ACL tears, so it can be less helpful. To evaluate these overall, though, with these injuries, you're going to have to get an MRI to actually visualize that cruciate ligament. All right, let's do a couple of these questions. What is the most sensitive test for ACL instability? Remember, that's the Lockman test. Next question, what are the risks of an ACL tear if it's left untreated? Well, you can get chronic knee instability, you can develop articular cartilage damage, degenerative arthritis as well, so it's not very good. All right, guys, let's get back to that lecture now.
The menisci are crescent-shaped plates of fibrocartilage on the articular surface of the tibia that act as shock absorbers by spreading compression forces from the tibia over a wider area on the tibial plateau. They are involved in the diffusion of synovial fluid, which provides nutrition and lubrication to the articular cartilage of the knee joint. Loss of the menisci usually results in rapid degeneration of the articular cartilage of the joint and eventual osteoarthritis of the knee. The menisci are wedge-shaped. That is, they are thicker at their external margins and taper to thin, unattached edges at the interior of the joint, forming cups for the convex femoral condyles to sit in. Their outer edges are firmly attached to the tibia by coronary ligaments. They are connected to each other at their anterior ends by the transverse ligament of the knee. The anterior ends of the menisci are the anterior horns. The posterior ends are the posterior horns. The medial meniscus is C-shaped and broader posteriorly than anteriorly. It is fused to the tibial collateral ligament and the capsule of the joint medially, and its horns are firmly attached to the intercondylar area laterally. Thus, it is not very mobile and is more prone to injury than the lateral meniscus. The lateral meniscus is nearly circular, smaller, and more mobile than the medial meniscus. It is not attached to the fibular collateral ligament or to the capsule of the knee joint. A ligament that arises from the posterior horn of the lateral meniscus splits around the posterior cruciate ligament to form the anterior and posterior meniscofemoral ligaments, which attach to the medial condyle of the femur. They appear to act in association with the posterior cruciate ligament in preventing sliding of the tibia posteriorly with respect to the femur. The anterior or posterior meniscofemoral ligament is absent in about 2/3 of knees.
All right, it's time for another clinical correlation. So now let's talk about meniscal tears. Now, the menisci of the knee normally provide shock absorption, so we can glide like gazelles while we run. But the meniscus can also tear, which can lead to a disruption of knee flexion and extension. Imagine sticking your finger in the hinge of a door and then trying to close that door. Your finger is going to get in the way of that door closing completely, and it's going to hurt. Now, a similar thing is happening with a meniscal tear. The torn piece of meniscus may obstruct the motion of the knee joint, potentially causing popping or locking of the joint and joint pain. Now, meniscal tears can be isolated or they can be associated with ligament injuries like what we just talked about in our ACL tears. So maybe you've heard or maybe you've been taught about the unhappy triad. Now, the teaching historically has gone like this. After a football player sustains a knee injury following a blow to the knee from the lateral side, there is a triad of tears or partial tears. So this includes the ACL, the medial, or sometimes called the tibial collateral ligament, and then also the medial meniscus. Now, it was, and sometimes is still taught, that this is the unhappy triad, but we have a news flash regarding this very subject.
Hello again, I'm Dr. Dallas Salvi with a quick medical news flash. For years, the O'Donoghue triad, or unhappy triad of the knee, was thought to consist of the ACL, the MCL, and the medial meniscus.
Oh, my ACL, my MCL, my medial meniscus. Oh, it's so terrible. I'm so unhappy. Oh.
However, recent studies have indicated that instead of the medial meniscus, the lateral meniscus is injured more commonly.
Oh, my ACL, my MCL, my lateral meniscus. Oh, it's so terrible. I'm so very unhappy.
And that's your medical news flash. Thank you.
Okay, that settles it. Now beware of this. Now you might run into some confusion regarding the unhappy triad later on testing. So let's go through a few of these questions, and then we'll move on to the actions and muscles of the knee, and then the popliteal fossa. So first question here, when the anterior cruciate ligament and medial or tibial collateral ligament are injured, is the medial or the lateral meniscus more likely to be injured? Remember, it's the lateral meniscus. Next question, what symptoms can occur with a meniscal tear? So we mentioned popping, locking, joint pain. You can also have instability. You can also have stiffness and even joint edema. Okay guys, let's move on to that lecture.
The knee joint is a synovial, hinge-type, uniaxial joint. Its two main motions are flexion, which reduces the angle between the posterior surface of the thigh and the leg, and extension, which increases this angle. There is also a degree of rotation about the knee joint. During the final 20 degrees of extension, the tibia and femur rotate with respect to each other. If the knee is extended while the feet are fixed to the ground, as when standing up from a squatting position, the femur rotates medially with respect to the tibia. If the knee is extended while the feet are free, as when one is seated and the feet are dangling off of the ground, the tibia rotates laterally with respect to the femur. This rotation occurs because the medial femoral condyle is longer than the lateral femoral condyle. For full extension to be accomplished, the articular surfaces of the knee must be brought into maximal alignment. In order to achieve maximal alignment, the bones must rotate to compensate for the disparity in the sizes of the condyles. You might see this process referred to as the screw-home mechanism. Extension finally stops when the collateral and cruciate ligaments have become taut from the twisting of the femur and the tibia with respect to each other, resulting in a position of slight hyperextension, at which point the knee is said to be locked. This is the most stable position of the knee. The articular surfaces are most congruent, and the slightly twisted ligaments are holding the bones together tightly. To flex the knee from the locked position, it is first necessary to untwist and loosen the major ligaments of the knee to prevent them from being excessively stretched. The muscle that unlocks the knee is the popliteus, which originates from the lateral surface of the lateral condyle of the femur, within the capsule of the knee, but not within the synovial lining, passes between the fibular collateral ligament and the lateral meniscus, leaves the capsule of the knee joint, and inserts on the posterior surface of the tibia superior to the soleal line. It is innervated by the tibial nerve. The popliteus unlocks the knee joint by medially rotating the tibia with respect to the femur, or laterally rotating the femur with respect to the tibia. Once the knee is unlocked, flexion can proceed. The actions of the popliteus then are unlocking the knee, medial rotation of the knee, and flexion of the knee. Rotation of the knee is stated as rotation of the tibia with respect to the femur. Other medial rotators of the knee include the semitendinosus and semimembranosus, while the long head of the biceps femoris is a lateral rotator of the knee. If you've watched the Solid Anatomy lecture on the thigh, you're familiar with the extensors and most of the flexors of the knee joint. The only muscles that extend the knee joint are the muscles that make up the quadriceps. They are the rectus femoris, the vastus medialis, the vastus intermedius, and the vastus lateralis. The rectus femoris originates on the anterior inferior iliac spine and flexes the hip joint, while the vasti muscles originate on the femur and do not act on the hip. These four muscles insert on the quadriceps tendon, which attaches to the patella, which inserts on the tibial tuberosity via the patellar ligament. The quadriceps are innervated by the femoral nerve. All the other muscles that cross the knee are flexors of the knee joint. These include the hamstring muscles, which are the semimembranosus, semitendinosus, and the long and short heads of the biceps femoris. The only hamstring muscle that is not innervated by the tibial division of the sciatic nerve is the short head of the biceps femoris, which is innervated by the common peroneal division of the sciatic nerve. In the medial compartment of the thigh, the gracilis muscle crosses the knee and flexes it, while in the anterior compartment of the thigh, the sartorius muscle crosses the knee and also flexes it. The gracilis is innervated by the obturator nerve, and the sartorius is innervated by the femoral nerve. Remember that the gracilis, the sartorius, and the semitendinosus have a common insertion tendon on the medial side of the tibia, the pes anserinus. 3 muscles of the leg also serve as knee flexors. We've already discussed the popliteus. The other 2 are the gastrocnemius, which has a medial and a lateral head, and the plantaris. For more information on these muscles, download the Solid Anatomy lecture on the leg and ankle joint. The diamond-shaped area posterior to the knee joint is the popliteal fossa. It is bordered superomedially by the semitendinosus and semimembranosus, superolaterally by the biceps femoris, and infiromedially and infirolaterally by the medial and lateral heads of the gastrocnemius. The roof of the fossa is formed by the popliteal fascia, which is the deep fascia between the fascia lata of the thigh and the crural fascia of the leg. The floor of the popliteal fossa is formed by the popliteus muscle. We last saw the femoral artery and femoral vein in the Solid Anatomy lecture on the thigh when they reached the end of the adductor canal and passed through the adductor hiatus. The hiatus leads them to the popliteal fossa, where they are called the popliteal artery and popliteal vein. They are accompanied in the fossa by the sciatic nerve, which often physically splits here into the tibial and common peroneal divisions. While in the fossa, the sciatic nerve gives off the sural nerve, which may arise as separate medial and lateral sural nerves from the tibial and common peroneal divisions of the sciatic. These nerves may remain separate or joined to form a single sural nerve, which supplies cutaneous innervation to the lateral part of the leg. Running up the posterior side of the leg and diving into the popliteal fossa is the lesser saphenous vein, which drains into the popliteal vein. The popliteal artery gives off 5 genicular arteries. The unpaired middle genicular artery dives into the joint space to supply the cruciate ligaments. The remaining 4 form interconnected anastomotic rings that encircle the distal end of the femur and the proximal end of the tibia. These are the superior medial and lateral and inferior medial and lateral genicular arteries. Also contributing to this anastomotic network are a descending genicular branch from the lateral circumflex femoral artery in the proximal thigh, and another descending genicular that branches off of the femoral artery just before it enters the adductor hiatus.
So that covers the knee. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. All right, let's get going. First question. What muscles are the superior lateral and superior medial and inferior lateral and inferior medial borders of the diamond-shaped popliteal fossa? So superior laterally by the biceps femoris, superior medially by the semitendinous and the semimembranous, and inferior medially and inferior laterally by the medial and lateral heads of the gastrocnemius. Next question. Of the tibia and fibula, Which is larger and bears all of the weight? That's going to be the tibia. Next question. What nerve innervates the quadriceps muscles? That's going to be the femoral nerve. Next question. Which leg muscle unlocks the knee from full extension? That's going to be the popliteus muscle. Next question. Which vein drains into the popliteal vein in the popliteal fossa? That's going to be the lesser saphenous vein. Next question. Which one of the collateral ligaments of the knee attaches to the joint capsule? So the tibial collateral or the medial collateral attaches to the joint capsule of the knee and is said to be capsular, while the fibular or lateral collateral ligament does not attach to the joint capsule of the knee and is said to be extracapsular. Next question. What name is given to an inflammation of the infrapatellar bursa? In the lecture, we said it could be called water on the knee, but another term that can be used is called clergyman's knee, and that's caused by friction between the skin and the tibial tuberosity, and that's due to all that praying. All right, guys, so we're almost done. Now, we've provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your examination. So label the images, and then we'll be finished. Thanks.